welcome everyone today. Thank you so much for joining us. We've got an hour packed full of information for you. I want to thank everybody for coming and just do a quick introduction of our hosts and facilitators today. My name is Danielle James, and I'm the Engagement and Learning Coordinator for Black Maternal Health and Reproductive Justice at Canadian Women of Color Leadership Network, CWCLN. I'm really happy to be here today with my co-facilitator, Erica Kamikaze, and Sophia Jacob as well. I want to give you guys a chance to just introduce yourselves really quickly.
Hi, everyone. My name is Erica Kamikaze. As Danielle just said, I work at Ottawa Public Health as part of a community engagement team. So working as much as possible to stream community engagement for health equity. And my role with CWCLN is to really just try to plan and coordinate and support a variety of workshops around women's reproductive health and chronic disease as well. But so happy to see so many of you rolling in, and I'll let Sophia introduce herself.
Good afternoon, everyone, and welcome. My name is Sophia Jacob, and I'm the CEO and founder of Canadian Women of Color Leadership Network. We're excited to have you all here for this workshop and enjoy yourselves, and chat again in the chat section.
Thanks so much. So we just want to begin with a land and ancestor acknowledgement and take a few moments. As we gather today, we acknowledge with deep respect the ancestral lands of the Algonquin Anishinaabe people, along with all First Nations, Inuit, and Métis peoples, whose lands we are privileged to stand upon. We honor their enduring stewardship of these lands. The Canadian Women of Color Leadership Network, CWCLN, recognizes that our office is located on the unceded and unsurrendered territory of the Algonquin Anishinaabe Nation. We express our gratitude for the opportunity to be present here today and reaffirm our commitment to working in solidarity to improve the lives of our diverse communities on this shared land. CWCLN is dedicated to the ongoing process of decolonization and fostering meaningful partnerships with Indigenous communities. We also take a moment today to honor, acknowledge, and give thanks to our ancestors, those who came before us, stretching back through time to those proud African queens and kings from whom we are all descended. We remember our roots and all our brothers and sisters of African, Caribbean, and Black heritage who laid down the path we now walk. We remember our shared heritage, we celebrate our great diversity, and we acknowledge the struggles our mothers and grandmothers overcame so that we could be present today. Today, we are the vessel of all their hopes and dreams. May their hands be on our shoulders as we do this work. So again, I just want to say thank you to everyone for coming today. I'm going to share a little bit of information about Black maternal health and reproductive justice programming that we've got coming up here at CWCLN. Today's webinar is part of our Black maternal health and reproductive justice programming. Starting in 2023, CWCLN has been actively working to raise awareness and advocate for change in the areas of Black maternal health and reproductive justice. Our impact report, which we did not a few weeks ago, will be posted on our socials and other platforms soon. And you can read more about the vital work we've been doing in the areas of advocacy, community building, and research. We will be hosting online and in-person events for Black women and femmes on reproductive issues at every age and stage of life, from periods to menopause. Our new webpage for Black maternal health and reproductive justice is going to launch soon on the CWCLN website, and you can check out our socials for more upcoming events. I'm going to pass it over to Erica. We're so excited to have our guest speaker here today. Erica, I'll let you do the introductions.
Thank you so much.
And
we'll continue. So Dr. Chantal Phillips is a newly minted family physician and incoming third-year resident in the Public Health and Preventive Medicine program. She earned her MD from the University of Ottawa in 2023. She's passionate about knowledge translation with Canada's diverse Black community, stemming from her own experience as a project manager for the Black Health Alliance Health Promotion Initiative from 2020 to 2024. Dr. Phillips is committed to advancing equity at the intersection of public health and primary care, with the focus on community-driven, evidence-based interventions. Donc aujourd'hui, nous sommes ravis d'accueillir Dr. Chantal Phillips, pour discuter des 3 problèmes de santé reproductive les plus courants chez les femmes noires, le syndrome des ovaires polycystiques, les fibromes utérines et l'endométriose. La session sera en anglais, mais si vous voulez à la fin qu'on aura la période de questions et réponses, vous pouvez poser vos questions en français, puis on fera ce qu'on pourra pour faire la traduction et l'interprétation. Welcome, Dr. Phillips.
Thank you for this opportunity, and I just want to commend you for all of the work that you're doing as an organization. A big part of the gaps of in our healthcare system are in part access to information. You know, when we're in communities that don't have a large number of physicians, of people training in that field, it can be very hard to access information about ourselves. And unfortunately, there also isn't enough research that's being done on Black women and Black non-binary folks. And so throughout this presentation, I'll be focusing on just one component of the many things that have to do with reproductive health. But a key part of this is the focus on health promotion. My goal today is to provide information on some of these common health conditions, and hopefully that information starts to pique some questions for yourself about your own health and allow for you to continue that process, that journey of seeking medical attention if you feel like this presentation evokes that for you. And also throughout the presentation, while I'll be using the word women, I identify that there's many people who are born female, but maybe don't identify with that as women. And so even though that term is being used throughout the presentation, it is inclusive across gender identifying individuals. So just here's some general information. So one, I have no conflicts of interest to disclose. The second is really the presentations for informational, educational purposes. While it may present cases about women, and in those cases you may see yourself, but it isn't for the purpose of diagnosis or for specific treatment. In order to get treatment that is specific to you as a person in the context of maybe any other medical conditions you yourself are dealing with, you do need to see a health professional. I'm also not an obstetrician or gynecologist. I just graduated as a family doctor and have experience in family medicine. So these cases are presented from the perspective of someone at the beginning of that journey of identifying their symptoms and coming to a family doctor. And so if you were hoping for maybe something a bit more specific or intricate, while we do touch on some of the management, it's not as specific as some of the surgical interventions that happen, et cetera. And lastly, as mentioned already, please, if you identify yourself in any of these cases, if any of these symptoms stand out to you and are things you're experiencing yourself, you do need to seek medical attention for further assessment. With that being said, so as Erica mentioned, the 3 things we'll be covering today are fibroids, PCOS, or polycystic ovary syndrome, and endometriosis. And we'll be presenting information in the context of cases with opportunity to engage, and then there will be opportunities for questions at the end. And if you happen to have questions at different points during the session, you can, jot them down for yourself and then ask them at the end, or perhaps enter them into the chat, just recognizing that we will be waiting to the end to actually address them. So we wanted to do a bit of an icebreaker. So for those of you who have your phones out, you can scan the QR code on the screen. I'll switch screens to the other option there, that's through Slido. And so if you want to join, you can go to slido.com and you can insert that number in order to be a part of this poll. But, to get you guys warmed up, because, I want some participation throughout the presentation. When you hear the phrase reproductive health, which emoji best describes your immediate reaction? Like, what is that gut feeling that you have? Is it, kind of confused? You feel like you maybe don't have enough information about your health? Is it like, I already know what I need to know? That's the glasses emoji. Are you like really obsessed with reproductive health and it's something you're really passionate about, and so you would choose the heart eyes? Do you feel like it's just mind-blowing, like you can't believe that like that bodies like ours are able to do the stuff that it's able to do? Or do you find that it's just really discouraging that you haven't maybe had the best experiences in the past, and so there's that sweat face? It's quite a difficult topic and a difficult experience that you've had. So far, we have a couple options. A lot of people right now are kind of unsure, it seems, that that's in the lead. We have some people saying, there's quite a lot of love for their bodies and what their bodies are capable of. There's some mind blown. What I do see is that not all of us feel like we're experts in this field, and myself included. One, because unfortunately, as I mentioned previously, has not been enough research in this area. And so even the things we wish we knew about some of these conditions, we don't know. And I'm hoping that we'll know in the next 10 or 20 years. So there is a lot of room to grow as individuals, but also as a field. So thank you for participating in that activity. And there'll be a couple of other opportunities to use the Slido as well in the future. Okay, so we'll start with our first case of Sylvia. Sylvia is a 36-year-old Black woman of Caribbean descent. She works as a high school administrator. She's married and had 2 pregnancies with 2 children, now aged 10 and 12, and this was by vaginal delivery. And she comes to the office with heavier periods for the past 8 months. So whenever I hear the word heavier periods or the phrase heavier periods, I ask myself, what is the primary concern? And really, that primary concern is encompassed by the medical term abnormal uterine bleeding. And that's the medical term we use. But for most people, one of the ways that manifests is through heavier periods. Really, the definition of abnormal uterine bleeding is quite broad. It's just irregular period or menstrual bleeding. And so it could mean different changes from your baseline in the timing of your period. When it happens in the cycle, so for example, if your period used to be, or your cycle used to be 28 days, and now it's actually 22 days, that would be a change in timing, change in the frequency. And so if rather than having bleeding at the end of your period, you're starting to have bleeding throughout your cycle. Duration, so if your period used to last 5 days and now it's lasting 10 days, that would be a change in duration. Or in volume, so if you're having not really that many other changes, but you're just noticing that your periods are either much lighter or much heavier. So all of these are encompassed under that phrase abnormal uterine bleeding. And there's a lot of different causes for this. This can be caused by, we call structural changes. And what that means is then when there's a change to the appearance of the uterus or ovaries, that's a structural cause. So if you were to look at it, and we'll have photos of the reproductive system throughout the presentation, but when you look at it, it just looks different than what you would expect it to look like. Anything that's encompassed under that is deemed a structural change. There's also non-structural causes, meaning if you were to look at the uterus, you looked at the ovaries, nothing looks different, but it could be changes in hormones or in other conditions, for example, family bleeding disorders. Any of those are non-structural causes that can still cause changes to your vaginal bleeding. And so all of that, as I mentioned, is encompassed under abnormal uterine bleeding. And we'll go into some common structural and non-structural causes, which is the point of this presentation. So PCOS, fibroids, and endometriosis, these are all encompassed under causes of abnormal uterine bleeding as one of the components. However, they also manifest in other ways. So there's a lot of things that can cause, as I mentioned, abnormal uterine bleeding, but the ones that we'll focus on are endometriosis, which we have to ask ourselves, where is this happening? And when you look at this diagram, endometriosis oftentimes is, and we'll talk about it further, is that this lining that's over here, when it ends up growing outside of the uterus, going into this area here, that's when it's called endometriosis. That tissue that's supposed to be inside is growing outside. And then so that's one area that's affected, is called the peritoneum, or it's just the pelvis. So anywhere in the abdomen that is not the uterus. The other things that are very common is polycystic ovary syndrome, and we'll talk about each of these conditions in more detail moving forward. I just wanted to give an actual like a diagram and explain what's happening and where it's happening. So as it says in the name, PCOS, the word ovaries there are changes that happen in the ovary, and we'll talk about why those changes happen. And then there's, we say intrauterine factors, which just means inside the uterus. And the one we'll be talking about is fibroids. And so those are, even though they can grow just on the outside of the uterus, like over here, the ones that cause some of the most trouble are the ones that are actually inside the uterus. So those 3 conditions, endometriosis tends to be most impactful when the tissue that's inside the uterus goes outside the uterus. There's PCOS, polycystic ovary syndrome, which is when there's issues in the actual ovaries, which are on the outside here. And this is where our eggs are developed. And then there's intrauterine issues that cause bleeding, which is inside the uterus, one of those being fibroids. Now that we have that overview, and as I mentioned, if there's ever a point of questions, please include them in the chat. We'll kind of proceed to Sylvia again. So Sylvia, as I mentioned, she's a 36-year-old Black woman of Caribbean descent. She works as a high school administrator. She's married and had 2 pregnancies with 2 children, ages 10 and 12 by vaginal delivery. And she comes to the office with heavier periods, so abnormal uterine bleeding. And this has been for 8 months. So now I'll open up the chat for questions. Are there other things you'd want to know about Sylvia's history and her bleeding? If this was something that was happening to you, what are some of the things that you'd be looking out for that maybe would make you more concerned? And you can use the chat for putting any questions or any responses that you think are relevant. And, there's no wrong answers, so, be encouraged. And also, if they don't have to be specific questions for Sylvia, they could just be general things about her health that you think are important for us to know. Yeah, great. Danielle, has she gained weight? Other thoughts? Also, think about what does a doctor or nurse practitioner ask you when you're meeting them for the first time. Yeah, great. Does she have any prior illnesses? Is she experiencing pain or discomfort, changes in mood? Is she on any type of contraception? Are her periods still regular? Great. A lot of wonderful responses here. Awesome. Is she on any medications? Give the chance for one more answer. These are all really great. Yeah, her hemoglobin, any prior history of miscarriages. You're all on a roll. This was wonderful. So thank you for participating. So this is a lot of information. I'm sorry, it's a bit of a heavier slide, but it's probably the most heavy slide on in the presentation, only because the condition we're talking about is one of the most common. So first is the history of her bleeding and any other symptoms that she's had. So I would want to know, she's talking about heavier periods. What does that actually mean? And for her, it means that she's soaking through a large pad, and this is every 2 to 3 hours on her heaviest days. And before, her periods were about 4 to 5 days, but now they're lasting 7 to 9 days. So not only are her periods longer, they're also heavier than before. And then other symptoms that she has is this pelvic pressure. It's not pain, but it just feels like a bit of a pressure in her lower abdomen. And she's also feeling like she needs to urinate, to void more often than she did previously. She doesn't have any other urinary symptoms. It's just needing to go more often. And she's feeling quite tired after each of her periods. In terms of her gynecological and family history, so that's also important to know, she is up to date for her cervical cancer screening. So that means she had her pap test about a year ago. That was normal. So there's no concern about cervical cancer here for the bleeding. She isn't currently on birth control because her husband had a vasectomy. She has a mom who actually also had a hysterectomy because she's also had what they called female problems. And the thought was that it may be fibroids. But she has no family history of any bleeding disorders to explain the bleeding. And in terms of her own past history, as someone mentioned, you want to know about any illnesses. She has been diagnosed with mild iron deficiency anemia. So that means that her hemoglobin is low, and it's because she's low in iron, which you can be low in iron if you're losing too much blood. And that was diagnosed 2 years ago. Her BMI is 30.2, and so she's what would be deemed borderline overweight/obese, and she has no history of high blood pressure, diabetes, or any other gynecological issues that she knows about. She doesn't smoke, and she drinks at most 1 to 2 glasses of wine per week. So it's a lot of information. It's a quite large history, and that's why, when it comes to some certain gynecological or reproductive health issues, they are like long appointments. So if you're going to the family doctor, which is, a 15-minute appointment, oftentimes it takes a couple appointments to be able to go through all of this information and have enough information to make a diagnosis and to talk about treatment. So I laid it out like this for you because I wanted to paint the picture that it can take a while to get to the bottom of why you're having some of the symptoms that you may be having, that Sylvia is having the symptoms that she's having, because it takes quite a lot of time to go through this history in a full way that captures the picture of her condition. So you use the QR code again, and this is to go to the Slido. If it's too difficult to use the Slido, you can also use the chat. So we've talked about a lot of different symptoms. What stands out to you about her case? Like, and what do you think is going on? What do you think she's dealing with here? It's one of three things. So, and we'll go to the, fibroids. Someone said loss of iron. Someone mentioned family history stands out. So we can use a combination of the chat or the Slido, whichever is more convenient for you folks. Any other things that stand out to you about her case that you'd want to know? Traveling. Oh yeah, travel history. Okay, that's a good one. And is there anything about what she said that you'd want that stands out to you? Yeah, blood to check hormones. Yeah, fibroids is a possibility. The pressure to pee. Yeah. So yeah, that pressure, that pelvic pressure without pain, is something that is really important to highlight. Other thoughts of things that about her that stand out to you? Oh yeah, abnormal bleeding, low iron. The opportunity for one more answer before we reveal. Yeah, you'd want to know, there's the weight component and how that can relate to her diagnosis. That's great. Family history. Yes, that one's really important. Thank you for saying that. Okay, great. So continue to, put things in the chat or to use the Slido, but we'll switch back over to the presentation. So fibroids, we got it. So this is a bit of information about fibroids. This picture really summarizes the condition well in a very visual way, if you're a visual learner. It's these kind of masses that form, and they are considered benign pelvic tumors. When we say that, that sounds really scary because you're asking, do I have cancer if I have fibroids? Especially because they're so common. But all a tumor means is that it's a mass of tissue that grows faster than it should and in a place that you wouldn't expect it. So it doesn't have to be, cancer in the way we think about cancer, as in the cancer that spreads to other parts of the body and can cause death. So that's not what fibroids are. They're benign, meaning that they don't have the capacity to spread to these other parts of the body and cause disarray. They remain within and on the uterus or the womb, and but the challenge is that they're structural issues. So if you can think about, there's only this tight space, and this tight space only has so much accommodation. So if you add this mass into that space, you're going to feel that increased pressure because there's less space. And so whenever there's this mass that's growing, taking up more space than it should, that's when it starts to cause problems. And that's where some of Sylvia's symptoms are coming from. So she had mentioned the heavier bleeding, but also that pelvic pressure. And there are some people who may have pain with fibroids, but it's not as common, even though it's possible. But it's more often pressure that's described. And that pressure, because it's that extra space, when you think about the uterus, the bladder is right above it here. So if there's something growing on the top of the uterus, it's pushing on the bladder and can cause someone to need to go to the bathroom more often because your bladder has less space. So that's one of the symptoms there. And then there's some people have constipation for the same reason. So there's the bladder that's here, and then a bit further up, there's the bowels up here. And so if you're having this big mass that's growing, especially there's some people who have masses even inside that are so large that they are competing for space and push the bowels out of the way and can make it harder for you to pass bowel movements, leading to constipation. So those are some of the symptoms. There's a lot of people who have them and they don't even know they have them. And they don't really cause a problem if they're small. It's when they're larger or if they're inside the uterus. Because if they're inside and someone is hoping to get pregnant, they have to be able to the baby has to be able to attach somewhere inside the uterus. But if it's trying to attach on a component or a part that's poking out, it doesn't attach properly, and then unfortunately that can lead to miscarriage. So that is where some of the complications of fibroids come. And the other complication, other than infertility, is the heavy bleeding, which we see happening to Sylvia. And the reason for that is that whenever there's a component pushing out, there's more space, so that instead of it just being flat, when it's protruding out like that, there's more blood supply, which means that there's more bleeding at the end when you have your period. And so that's why some of that heavier bleeding can happen with fibroids inside the uterus. Some other risk factors are Black women, people living with obesity, those who have a family history of fibroids, definitely a genetic component, which we pointed out there. And then for her, she has this mild history of iron deficiency anemia, where her hemoglobin's been low for 2 years, and we wonder if it's because she's been having these heavier periods over that time. So in the context of fibroids, I want to really stress that point, like that it's very common. It's not a cancerous tumor. It's a mass that grows that can cause issues if they become too big. And the concerns we have with them, if they're not treated and they're really large, is you're losing too much blood, and so you get anemia. And if you're trying to get pregnant, they can cause infertility. So they are important to think about and address, especially if you've been trying, or if someone's been trying to get pregnant and they're having difficulty. It's one of the things we consider. Okay, so what happens next? Sylvia goes to our family doctor and she gets an ultrasound. The reason I put the 2 types of ultrasounds is because if you're ever in a position to get an ultrasound, you need to be aware of the 2 types. So there's transabdominal, and this means they take that, I don't know if you've ever had an ultrasound, they put jelly and then they have this probe and they rub it over that area. Abdominal means they're putting that jelly on your abdomen and they're using the probe on your abdomen to see your uterus. Transvaginal is there's the probe, a small probe that goes into the vagina. And while I know for some, especially if there's a past history of trauma, that can be, a scary thought. But the difference between these 2 is that the abdominal only gets the upper view, whereas the vaginal gets the lower view and ends up showing more of the uterus. And so it is something to consider. I just want to make sure that if you're ever in that position to get an ultrasound, you're well informed about why they are asking for a transvaginal. However, you always have the ability to consent or not consent to proceed with those procedures. So when Sylvia gets this ultrasound, she gets both of them, and they do show a very large intrauterine fibroid, meaning a large fibroid inside of the uterus. Because of this, she's referred to a gynecologist. However, the wait time for a gynecologist in Ottawa and in many places is 1 to 2 years for a consultation. So you're waiting and then the gynecologist, at the end of the day, they are surgeons. And so when you're going to see them, one of the things they think about, one of the things that they're good at that a family doctor cannot do, is surgery if they feel that's indicated. With how large Sylvia's fibroid is, it is something that would be considered if she was aware of the risks and wanted to proceed. In the meantime, because the wait is so long, and the longer you wait, especially if you have symptoms from the fibroid, the more it has a chance to grow. Because of that, she does decide to proceed with birth control, which is an IUD. And the reason for that is because those hormones do end up slowing the growth of the fibroid, so that while she's waiting for consultation, it's not even larger than it was when she was first being diagnosed. So that's one of the options that we consider for management of fibroids, especially if someone doesn't want to proceed with surgery or is waiting for surgery. And then the other thing she does, which does have opportunity for benefit for improvement, is she joins a local walking or running group, and this is to increase her weekly exercise. The reason for this is by lowering her BMI or body mass index, that weight loss does help to slow the amount of growth of the fibroid. And that's because fat tissue has more estrogen or sex hormone in it, which grows the fibroid. So weight loss or exercise can actually slow the growth of the fibroid, and for some people be enough to keep their fibroids stable. So for those who are not interested in hormonal options, exercise is one potential option to consider. However, if it's too advanced, that on its own will not be sufficient. We're going to move on to case number 2. This is Cassandra. Oh, sorry, I said Sylvie here. That is Cassandra. Cassandra is a 26-year-old Black Nova Scotian woman. She is currently in graduate school for education. She does not have any children, but she is interested in having children in the future. And she comes to the office with a 3-year history of progressively worsening pelvic pain. And so she is in pain. And this pain is worse during her periods. And this is resulting in her missing many of her classes, especially during her period. She has had some heavier periods during this time, along with painful bowel movements and and pain with sexual activity. So she has a lot of pelvic pain. It's worse during her periods. She does have some heavier periods than she used to, but that's not her main concern. It's more the pain that's bothering her. And it's the pain that's associated not just in her pelvis, but also with bowel movements as well as with sexual activity. So that's what she's going through. And she's been going through this for a long time. She's been going for 3 years, and it's starting to affect her education. So with this in mind, we can go back to the Slido one more time. And I want to ask us the question, what's similar versus different about Cassandra's case when compared to Sylvia's? So for example, like, are there certain symptoms that are different than the symptoms that Sylvia went through, that she is going through? Are there other things about who they are, their ages, or, what's different about these 2 cases? And I do this because it's important when we think about the difference between these 2 conditions. So you can go to that QR code. And then we're going to this final slide here. Also, feel free to use the chat if you're more comfortable with that. Yeah, exactly. Cassandra has pain outside and during her period. There's bowel pain. Yeah, so similarities, they both have some changes in their bleeding. When you look at Cassandra, her age, she's younger, and the length of her pain. So she's had her symptoms for 3 years rather than 8 months. So that's a very good point. Anything else that strikes you, either similarities or differences between Cassandra and Sylvia? Yeah, pain during intercourse and bowel movement. So Sylvia had some pain with urination or voiding, but she didn't really have pain with bowel movements or with and she didn't mention pain during sex. But this is something that Cassandra is experiencing. Yeah, exactly. And also, so Cassandra doesn't have any children yet. Yeah, her origin story, definitely. Bowel pain. Wonderful. Thank you for participating. Okay, so let's transition back to the PowerPoint. Yeah, so the difference here, so you identify all of those differences, and I'll go through them, but what those differences are related to is the difference between fibroids and endometriosis. So some of the things you had rightly pointed out, you pointed out that she's been going through these symptoms for a long time, 3 years. That doesn't mean that you can't have fibroids for many years, but what happens is as they kind of grow, people start to notice them. Whereas endometriosis, unfortunately, despite it being quite common, so 5 to 10% of women of reproductive age have the condition, it's highly underdiagnosed, in part because we don't have any good ways of non-surgical ways of diagnosing it. So imaging modalities like ultrasound or like MRI, while they may, in a very, very slim number of opportunities, pick up something that suggests endometriosis, it is often not enough. And so the way to diagnose it is through surgery, being referred to gynecology, and having to undergo a surgery to identify these lesions that we're seeing here. And when they see them, that's how the diagnosis is made. So that's the challenge here. Some of the other symptoms that we notice the difference is here is the pain. So while fibroids can cause pain, they more often cause pressure. Like, it doesn't mean that you can't have pain with fibroids, but the defining feature of endometriosis is pain. If you don't have pain associated with your periods, then it's like it can't be, or very unlikely to be, endometriosis. The other thing is the pain is associated with not just your periods, but across a couple different areas. So pain with sex, specifically like penetrative sex, pain with bowel movements, and then pain with voiding. And that is one similarity a difference between Sylvia and Cassandra, because even though Sylvia, who had fibroids, had increased voiding, so she was going more often, she didn't have pain when she was voiding, whereas with Cassandra, she has pain when she's voiding. So really what endometriosis is it's an inflammatory condition, meaning that when this tissue that's on the inside of the uterus, that's the part of the uterus that when we have a period, that it comes out, it empties. That part, that tissue, it's when it grows outside of the uterus, so in some of these spots we're seeing here, the issue is it's supposed to be confined inside the uterus, but when it grows outside, it does the same thing that the tissue inside it does. Every month, it starts to grow, and then at the end, with a period, it starts to bleed. The issue is if you're getting bleeding outside of the uterus, it's rubbing against your bowels, it's rubbing against your bladder, and when it's rubbing against those structures, the nerves feel that and it causes pain. So that's the difference there. With fibroids that are outside the uterus, like for example, fibroids outside, they aren't changing every single month. They're not bleeding. So the body doesn't really interpret that as often as pain unless they're really large. Whereas with endometriosis, that tissue every month is bleeding, and that blood is it's an irritant. It rubs and it gets all into these different places, and that's why it causes pain. And so that's the challenge with endometriosis. And unfortunately, as I mentioned, despite how common it is, it really is underdiagnosed, and I think the average number of years for diagnosis is 10 years. So I definitely resonate with people who experience a lot of pain with their periods and just pain with a lot of these other symptoms, and then it takes a long time to see a gynecologist, and then a long time to be diagnosed. Some risk factors here include family history, no prior history of having children, and so in part that is because like when you have had children, it's more of I would say if you have the capacity and the ability to have children, then you're less likely to have endometriosis. So it's more related as opposed to a cause. So for example, if you decide to have children, that doesn't mean you can't develop endometriosis. It just means that if you have had children, and you've successfully, like you've been able to deliver a child and go through a pregnancy, it means that because that has happened, you're less likely to have had endometriosis, because endometriosis can cause infertility. So if those who who haven't been able to bear children are more likely to have endometriosis because of the endometriosis, if that makes sense. And I can explain that further if anyone needs more questions about that. But I don't want you to go away thinking if you're 23 and you haven't had kids that you're higher risk of endometriosis. That's not having children does not prevent you from developing endometriosis. The other thing that is, even though there's a lot of, unfortunately, we don't have enough information about why endometriosis happens. The other thing that's been noted is sometimes for some people, if during their period, instead of the blood coming out, like straight out, if it goes up into the tubes because it's kind of going different places, that can increase the risk. And that's one thing that they have been able to show, but that's also has a genetic link. And so if you have family history of endometriosis, it may be because of where the blood is going at the end of your period. And if your mother or your mother's mother had those changes to the structure to cause that, you're also more likely to have that happen. And then the last thing is not as many links, but it has been identified in a couple of studies, is that diets high in red meat and trans fats may be linked to endometriosis. And in our current society or culture where that's more common, I could see why the rates of endometriosis are also increasing. Okay, so what happens next? So Cassandra, she goes to her family doctor and she has an ultrasound. The reason for the ultrasound is to assess for other causes. There aren't any significant findings on the ultrasound. And as we mentioned, ultrasound doesn't diagnose endometriosis. It just identifies that you don't have fibroids or you don't have other things to explain the symptoms. So in this case, she doesn't have fibroids or she doesn't have other things that are picked up on ultrasound. But that doesn't change the fact that she may have endometriosis. So she does still need to go see a gynecologist. And that this is because of how long her pain has been happening for. And there is really only that one way of diagnosing it, which is through surgery, through a gynecologist. In the meantime, she is encouraged to take naproxen during her periods. Unfortunately, it only does so much. She is still in pain. But the other thing to consider is if you are having endometriosis or we're concerned about endometriosis to the point that it's significantly affecting your training or your job, if you're especially in school, there is an accommodation letter that could be written, and especially during that time of the month. And so that is one thing that is more flexible in school, unfortunately, than it would be in the workplace, but is something that is offered to Cassandra to support her during that time. Okay, so this is the last case. And it still says Sylvie, my apologies. Blessing is a 22-year-old Nigerian woman. She is currently completing college studies to become an esthetician, but is becoming increasingly self-conscious, and this is due to increased acne. This lady does not have increased acne. I could not find any pictures. I'm sorry. But imagine she has increased acne, that she has dark patches of skin on her neck, and she's having increased hair growth on her chin, on her chest, on her lower abdomen. And she's quite frustrated with unexplained weight gain, despite no major changes in her diet or activity level. And her periods are irregular, but they've been this way since she's 18. So for her biggest issue isn't necessarily that her periods are irregular. She's not bothered by that. She's more bothered by the weight gain, the acne, the hair changes, the skin changes, and that's what she's presenting with. So what stands out to you about her case? And you can use the chat for this one. Hair growth. Yeah, good question. Think about thyroid, that's definitely important. Unexplained weight gain. Yeah, sounds hormonal. Body reactions, hormonal concerns. These are great answers. Any other thoughts? Does anyone have a suspicion of what it is? There's one option left. Yeah, there you go. Yeah, so PCOS. And I'm glad that someone had said thyroid issues, because that is true. That's something that we have to think about for sure. PCOS, or polycystic ovary syndrome. So this is a condition where it's back to a hormonal imbalance, meaning when there's elevated levels of male sex hormones, those are called androgens, but we'll refer to them as male sex hormones. They can result in these small sacs or cysts, kind of that you see here in this photo, and those are in the ovaries. All of that small sac is really when there's multiple kind of eggs preparing at the same time because of these high hormonal levels, there's a lot of those of those eggs that are almost ready but not quite, because there's so many hormones, and so they cause very large bulky ovaries, and that's why we say polycystic ovary syndrome. This one is very common as well, and it's about 8 to 20% of women of reproductive age. And the other things we think about here that Blessing has, there's irregular periods or cycles, there's increased hair growth, acne, obesity, and then or I should just say weight gain, because you may not have obesity, but there may be weight gain. And then the thing that I highlight here is insulin resistance. And so those dark patches that she was noting kind of on her neck, that's called acanthosis nigricans. And that is a sign of insulin resistance, meaning a sign that you are developing or may develop diabetes. And that is one of the most commonly linked or associated conditions with PCOS. And that's why it's so important to diagnose, because by intervening, we're able to not only help with fertility, but we're also able to help with decreasing the risk of developing diabetes, and what that means for your future your future health, but also for fertility, because during pregnancy, if you had PCOS, you're at a high risk of developing diabetes in pregnancy, which of course puts risks to yourself as well as to a child. So that's why those are some of the things we have to look out for whenever you have someone presenting with this condition. And so in terms of what happens next, and some have already started putting management, or so some people have mentioned thyroid, which is awesome. In the chat, you can put other management options for PCOS as well. So Blessing unfortunately doesn't have a family doctor, but she goes to a walk-in clinic, explains her symptoms, is examined, and the doctor says, yes, these are a lot of the similar features or signs of PCOS. So she receives blood work to assess her sex hormones, thyroid, which is great that you mentioned, and then for diabetes or insulin resistance. And then she also gets a transvaginal ultrasound. And in this ultrasound, they do see multiple cysts in her ovaries. And there are enough cysts, and they're big enough to meet the criteria for PCOS. So there are some, and I say that because you may have a lot of these symptoms and it may be very early, but if you get an ultrasound and the ovaries are not large enough to meet the criteria, you may not actually be diagnosed with PCOS, even though you have all the symptoms that may be leading in that direction. And so some people may go through that process and it may be discouraged because they have a lot of the features, but there are some cases where while the ovaries themselves may not be very large, they have other features clinically that would still suggest PCOS. So you can still be diagnosed with PCOS if you have some of those other features like the hair growth and the weight changes and the acne, even if your ovaries don't necessarily look that abnormal. So it could be either or, the ovaries or the other features on exam. Because there's also people who present with sometimes infertility or infrequent periods, and they don't actually have the hair changes or the skin changes, and they're discouraged because they don't know why this is happening. And then but on the ultrasound, it does show that there's the ovary changes without some of the like outgoing or outlooking like hormonal changes, like with the skin and with the hair. So either or is enough to meet the diagnosis, but the presentations can look very different based on which of those is being affected. So I present a case that's quite obvious in terms of the outward appearance, but know that you may not have some of those outward changes, but still meet criteria depending on what your ultrasound says. So with that in mind, what are the management options for PCOS that you have heard? I know we already had some starting in the chat. And pretty much what I'm asking here is like, if someone had PCOS, what would you do for them? Like, what would they need in order to treat or manage their PCOS? Yeah, great. So hormone replacement or like birth control, things to stabilize those hormones because the cause is a hormonal imbalance. That's great. Other thoughts? Yeah, weight loss. And the weight loss can be so hard to achieve with PCOS, but there's been science to show that if 10% weight loss can actually reverse the condition for some people. Yeah, exercise and diet. That's great. Change in diet. Yeah, great. Manage acne, ovulation. We got them all. So, in terms of what happens here, because Blessing doesn't have a family doctor, unfortunately, she is referred to a women's health clinic, and there are a lot of women's health clinics that are run by like family doctors who have additional training in women's health, and the wait times for that tend to be quite a lot shorter than those for gynecologists. Not saying you shouldn't be referred to gynecologists if that's not your preference, or sorry, if that is your preference, but if you're looking at wait times and counseling, family doctors are trained to be able to do counseling. The biggest issue is time constraints because they can be longer appointments. So if you have some of these issues, you identify yourself with some of these presentations, then do a search for like what women's health clinics exist in wherever you are, whatever city you're in. And there are likely going to be family doctors who have women's health practices where their wait times, instead of it being 6 to 12 months, is more like 1 to 3 months. And so you'll be able to be seen much earlier. But when she finally gets to that women's health clinic, she is counseled on hormonal management options, as mentioned. So that includes birth control in this case. And the issue here, and I'll explain it, is that because I know that there can be concerns about birth control, like any medication, of course, there are side effects, there are risks, are alternatives. In this case, though, because it's a hormonal issue, meaning there's too many male sex hormones competing with female sex hormones, by giving birth control, which has female sex hormones in it, so estrogen and progesterone, it brings those levels up high enough to decrease the size of those ovaries and to be able to help with managing some of those side effects or symptoms. So that's the rationale for birth control is while it is beneficial for contraception, so protecting against pregnancy, it is also important for trying to correct some of those hormonal imbalances. And just even for people who start birth control, that doesn't solve the whole issue. While it begins the process, I would say the best case scenario would be being on birth control while concurrently managing diet, exercise, and stress. Because while on birth control, you'll be more successful doing some of those changes with diet, exercise, and stress. And if there could be a sufficient amount of weight loss for those where it's indicated, then there is possibility of transitioning off of birth control if those lifestyle changes have resulted in a sufficient amount change where your hormones have stabilized on their own. So it's not a forever option for those who may be worried about it, but it could be something you use in addition to lifestyle to be more successful with those lifestyle changes. And so she chooses the birth control patch in part because it is a bit more of a steady release of hormone as opposed to a burst that comes with the pill. And it's just easy. She doesn't have to think about it. She thinks about it once a week, and that is it. So it was the best option for her as a student. And she decides to join an exercise program at her local community health center. And she actually meets 3 other women who have PCOS because it's such a common condition. And being in that community of people who have it can be really helpful in terms of getting that encouragement to be able to continue managing it. And then she was also given a topical medication for her acne. And then she is thinking about ways of over long term saving up for laser hair removal therapy. In the meantime, she is manually removing some of that extra hair, but she's also hopeful that while being on lifestyle measures and the birth control, that she'll get to a stage where the hair control is managed hormonally because it'll improve overall her condition will improve. In the meantime, she was going to save for laser hair removal just in case. Great, so that's the last case. I know we have about 4 to 5 minutes left, and I wanted to make sure there's some time for questions.
Yeah, we have a few questions in the chat, and then we'll invite people if we have time to continue dropping their questions in the chat. The first question was, can you speak to when one has problem when the endometrium is a bit bigger, a 6 instead of a 5?
I think maybe they were referring to are you referring to the size of the fibroids?
It
Or
was
like,
endometrium is a bit bigger, a 6 instead of a 5.
okay. I'm not sure if they mean millimeters, but it depends on the age and of course like the situation. So I always say like this is not specific medical advice to you as a patient. So take everything I say with a grain of salt and my limited perspective on your condition. But the things that come to mind, like for example, if you get an ultrasound, it'll show you how thick the endometrium is, and you'd hope that it would be less than we say a centimeter or less. Centimeter is when it's quite large, depending on which part of your cycle that it's happening. But if you had, I'm assuming you may have had an ultrasound, and so it showed that it was 6 millimeters instead of 5 millimeters. And if you're above the age of 40 and you've had any changes in vaginal bleeding, then that would be a sign to consult a doctor about potentially doing taking a bit of tissue to assess it to make sure that it's healthy, called a biopsy. If you're having concerns with bleeding. So that's what comes to mind there is like assessing for, endometrial cancer if you're above the age of 40. If you're under the age of 40, then there isn't really a harm associated with that.
Thank you. Another one was, are there any dangers of the late diagnosis of endometriosis?
Yeah, so I would say that the dangers that are most common are more so related to like infertility and to chronic pelvic pain. So meaning that even after when you've had those nerves be irritated for so long, for, you know, some people it takes 10 years to be diagnosed, then even after they do a surgery to remove those extra pieces of tissue that are outside the uterus, they may still have irritation or pain in their pelvis because the nerves themselves are so active. So there's nothing triggering those nerves, but because they've been triggered for so long, it leads to chronic pelvic pain. So that is that's one, I would say, danger there as well. And then other than that, honestly, just quality of life, that unfortunately, if you've had a condition for that long, you know, it affects every aspect of your life potentially. And it means every single month for a week to sometimes a week and a half, people feel like their lives are halted. And so it's definitely something we need to diagnose more consistently.
For sure. Thank you. And another one was, how come endometriosis symptoms decreased after having children?
Yeah, so it's more that, and I think that was perhaps didn't do the best job explaining. So a risk factor for endometriosis, meaning that like a link, a factor associated with people who have it. So what they did is they look at all these people who have endometriosis. They think, what do these people have in common? And the thing they had in common is that they haven't had children yet. But that doesn't mean that it causes endometriosis. It just means that it's more likely that if you've had a child already, that you don't have endometriosis because you were able to have a child. Whereas those who have endometriosis often have a harder time having children. So that's the thing they have in common. But having a child doesn't necessarily significantly decrease the risk of it. The one consideration is similar to like birth control. You know, if pregnancy, you're halting your periods from happening, and so your endometrial lining is it's not changing as much because there's a baby in there. So that's the one other consideration that may mildly decrease your risk is by being pregnant, your endometrium is not changing so much, so it doesn't have the ability to go out or grow out of the uterus. So some evidence may say that that's why it decreases the risk of endometriosis, is that but for 9 months your endometrium is not changing, it's stable. And if you have multiple children, you have maybe potential years of time where your endometrium is not changing, it's stable. So that may be the one other like research-based reason, but oftentimes it's also because those people who have it aren't able to have children.
Thank you for that. I don't see any other questions, but it's also 1 o'clock. So I think we're gonna wrap it up. So thank you so much today, Dr. Chantal Phillips, for sharing your presentation, but also answering so many of the questions. And I feel like I've gained so much knowledge through this presentation. And thank you everybody for joining and for participating and asking questions. Have a great rest of the week. And yes, thanks again for joining us for today.